Our webinar today is about endometrial optimization in frozen embryo transfer cycles. And we will kick off by the first presentation by Professor Hassan Maghraby. Professor Hassan Maghraby is a professor in Alexandria University. Please make a start, Professor Hassan.
Thank you very much, my friend. I would like to welcome all the attendees. I would like to welcome all our guests, especially Professor Kasper, Professor Bedewi, and Professor Botros. I would like to welcome all the other professors from Iman Gendi, Ahmed Youssef, Mahdi, Sharif, Sabri, and Gibril. I would like to thank all my co-founders in EFRE for their efforts. And I would like also to thank IPSA very much for their continuous effort for supporting the scientific activities of EFRE. And I would like to thank the administration of EFRE, particularly Mrs. Raghda for what she's doing, and Free-Fly for their excellent work in the IT. So endometrial thickness is related, but not directly correlated to increasing circulating estrogen. And thickness is related to endometrial receptivity, possibly, and success in ERT, which is also a controversial issue. And there is considerable controversy regarding significance of thin endometrium. Around 19,000 frozen thawed embryo transfer were studied by Liu et al., and endometrial thickness of less than 8 millimeter was found in 14% of cycles, less than 7 millimeter in 3% of the cycles. So this is the magnitude of the problem. 3% if you consider 7 millimeter as thin endometrium, and 14% if you consider a thin endometrium is 8 millimeter. Before going further, we have to know how to measure endometrium properly, because Professor Kasper warned me that this is very important. And the endometrium should be measured in sagittal plane along the long axis of the uterus. And the measurement should be from the thick echogenic part to the other thick echogenic part, and the translucency of the last part of the endometrium should be escaped. And the measurement should be done at the thickest portion of the endometrium, which is usually 1 millimeter below the tip of the endometrial stripe. The sources of error in endometrial measurements are using different machines, different angle of sonation, because you have to be perpendicular on the endometrial stripe. And studies have shown that there is an intra-observer variation of 0.5 millimeter and inter-observer of 1 millimeter in measurement of endometrial thickness. So this is important. Uterine contractions also can cause changes in endometrial thickness mounting up to 3 or 4 millimeter, which is very confusing. And a reasonable technique would be to wait till contractions go away. So again, my friends, endometrial thickness during ART could be evaluated either at the end of estrogen treatment or after progesterone treatment, after a few days of progesterone treatment before embryo transfer. As regards endometrial thickness at the end of estrogen treatment, from the Canadian registry, Kimberly et al. Showed that in young age women, live birth decreased significantly in fresh cycles when endometrium was less than 8 millimeter in thickness, and in frozen cycle when the endometrium was less than 7 millimeter in thickness. So two numbers, 7 and 8, 7 for frozen. In old age, the same thing, the pregnancy decreased, but when endometrium was less than 6 millimeter. So for old age, you can tolerate a thinner endometrium. As regards, again, endometrial thickness at the end of estrogen treatment, the second paper, this is a large retrospective study of frozen embryo transfer. And they indicated that when the endometrial thickness in frozen cycles was below 6 millimeter, clinical pregnancy was 34% and live birth was 26%. Whereas if the endometrial thickness increased above 6, the pregnancy rate ranges from 66 to 69 and the live birth from 46 to 55 to 51. And it doesn't matter whether the endometrium is 6, 7, 8, 9, 12, or 11, or 15, or 14. The pregnancy rate is not predicted from these measurements. So thin endometrium is an infrequent but challenging occurrence, of course, in assisted reproduction. And currently, there is minimal evidence to support specific protocols or adjuvants for this thing. At the end of estrogen phase, endometrium less than 6 millimeter is predictive of poor outcome. But endometrial thickness from 7 to 14 is a poor predictor of better pregnancy. So if it is less than 7, more than 7, you don't know where is your implantation window. In other words, if you have endometrium below 6 millimeter, you can continue treatment till 7, and the implantation window will seems to be open. But if you have an endometrium more than 7, on day 8, you don't know what to do actually. You don't know when to stop. Would you stop at day 9, 10, 11, or 12? So there is a problem. If the endometrium exceeds 7 early, you don't know what to do. And this is why the nice idea of Professor Casper came into play, because if thickness is not predictive, possibly a decrease of thickness after progesterone, which is called compaction, would be predictive. So compaction refers to a change of thickness from the end of estrogen phase to the time of embryo transfer. And if this decrease is, for example, more than 15%, then you can have a better outcome with this decrease in thickness, which is called compaction. So 8 years after Casper announced it is time to pay attention to endometrium, he introduced the idea of endometrial compaction as a predictor of pregnancy. If we look carefully at their protocol from the 2 studies they presented, estrogen was started orally or vaginally at day 2 or 3 with or without agonist suppression, and vaginal ultrasound was done 10 to 12 days after the start of estrogen. And if at that time the endometrium is more than 7, progesterone was initiated, and if not, estrogen was continued until the endometrium exceeded 7 millimeter. But remember, in both the studies of Casper, 219 and 220, women included had endometrium more than 7 millimeter at the end of the estrogen phase. As regards the progesterone, in my opinion, this is a low dose of progesterone. They used at that time low dose of progesterone. They used intramuscular 50 milligram daily, or vaginal 100 milligram endometrine 3 times daily, or vaginal micronized progesterone 200 milligram 3 times daily. This is the dose of progesterone that they used. The blastocyst was warmed in both studies at day 6 and transferred using transabdominal ultrasound guidance. And endometrial image has to be sagittal, and it has to include the cervical canal in it. Images were retrieved by a software after that, and measurements were confirmed by 3 authors. And the difference between endometrial thickness at the end of estrogen and the day of transfer was calculated, and this delta change was called compaction if it is a decrease in thickness. In the first study, 2019, published in Fertility and Sterility, it was a retrospective observational cohort study of 274 fed cycles. They were all treated with hormonal replacement, and the ongoing pregnancy rate was significantly increased at all levels of compaction compared with no compaction. So it increased whether compaction was 5, 10, 15, or 20. And this was the result of the first study, that compaction is a good indicator of better pregnancy rate. In the second study, they came up with a nice idea that they will transfer only single euploid blastocyst after PGTA to eliminate the endometrial factor from the equation of implantation. And so they transferred with the same protocol, but single blastocyst. And as you can see from this nice figure, if compaction was 5%, for example, the pregnancy rate was 44%, whereas if no compaction, it was 30. But you can see here at 15% compaction, when the endometrial thickness decreased at the day of embryo transfer by 15%, the pregnancy rate was 50-something% as compared to 30%, and this was a significant change. So compaction at this time, at this level, was significant in Professor Casper's study. So endometrial compaction is associated with significantly higher pregnancy rate in women with more than 7 millimeter endometrial thickness at the end of estrogen treatment. The strength of the study is that the hormonal therapy is standardized. The day of start is standardized. And all women who had endometrial thickness more than 7 millimeter. And in the second study, of course, the strength was that they used euploid blastocyst. The weakness, it is a retrospective study, and the use of abdominal ultrasound, although they used a technique that can eliminate variation to a large extent, and in my opinion, those of progesterone. Opposite to what Professor Kasper did present, was a large Chinese study of 3,100 patients, and endometrial thickness in this study was measured at the end of estrogen and at the time of embryo transfer using vaginal ultrasound, and the change of endometrium was calculated, and they had a percentage of compaction around 25%, I think similar to what Professor Kasper had, or lower a little bit. And this, to our surprise, when compaction occurred, the pregnancy rate was around 36%, whereas when endometrial thickness increased at the day of transfer, the pregnancy rate was 60%. So this was in contradiction to the findings of Professor Kasper. So the study of compaction, and this was the idea of this journal club, is a very interesting and exciting concept, and endometrial compaction and its influence on embryo transfer is really interesting. But there are a lot of open questions. Does the degree of compaction vary from cycle to cycle? Does the degree of compaction vary with variation of the treatment in the same patient? Is compaction truly a marker of endometrial receptivity? Does compaction mean only that progesterone is working, or that it is associated with ultrastructure and molecular changes corresponding to a window of implantation? Is it worth canceling a cycle if there is no compaction, as the author suggested, Professor Kasper, in their study? Can we cancel a cycle if compaction did not occur? And from a research perspective, what kind of basic research or clinical trials are needed to further support the findings from this study? But the big question is, if the findings remain solid, what can we do to increase compaction? And the answer to all these questions will be provided by Professor Kasper. And thank you very much